Welcome back to the Deep Dive. Today, we are undertaking a really critical mission. It's something every nursing student in Canada has to get their head around before that first maternal-child clinical placement.
Right.
We're talking about synthesizing the foundational context of care. So we're going deep into the source material, the chapters that really set the stage to understand that huge systemic, social, and cultural blueprint that influences, well, every birth, every diagnosis, every single intervention you're going to perform.
And that's exactly it. The central theme for this deep dive is what we're calling the foundation of contextual care in maternal child nursing.
Okay.
It's this essential realization that safe and really effective practice. It demands that you as a nurse look far beyond the immediate clinical diagnosis.
So it's not just about the gestational hypertension.
Not at all. I mean, if you only see the patient with gestational hypertension, you're missing the crucial fact that their housing instability or their lack of transportation or their cultural beliefs are profoundly dictating their health outcomes. We have to master the clinical skills, of course, but we also have to get the complex layers of social, familial, cultural, and community contexts.
So that's why we've connected chapters 1, 2, and 3 into one single cohesive narrative for this deep dive. We're starting with the macro systems, the big Canadian context, and health equity.
And then moving inward.
Exactly. Moving inward to the really intimate level of the family unit. And then finally, we'll look at how you actually apply all that understanding as a community health nurse. It's like a progressive blueprint for holistic practice.
And let's just clarify the scope here. When we say maternal child health, or MCH nursing, it's broad. It includes perinatal nurses, so they're guiding families from preconception all the way through the childbearing year.
And then pediatric.
And then pediatric nurses, who care for children from birth right up to 18 years. But the defining principle for both groups is that the target of care is always the entire family unit. It doesn't matter if that care happens in a hospital, a home, or a public health clinic.
All right, let's dive into that big picture then. The framework that defines healthcare in this country. We all know the name, the Canada Health Act, but what are those 5 principles that actually anchor Medicare?
They are the 5 pillars. They define health insurance across every province and territory. So you have public administration, comprehensive care, universality, portability, and accessibility.
And what that means, in theory.
In theory, it promises that all residents are guaranteed coverage for medically necessary hospital and physician services. The whole idea is that payment is based on need, not your ability to pay.
That sounds like a perfect system on paper. But we know accessibility doesn't mean everything is accessible or covered. I think the key takeaway for you listening shouldn't just be that list of principles, but knowing where the gaps are.
That's the critical point, yeah.
Where do those principles fail to extend, and where does health and equity start to really exploit those vulnerabilities?
Well, that's it. The Act generally does not cover some really essential components. Things like home care services, long-term extended care, most pharmaceuticals once you leave the hospital, or dental care.
And those are huge.
They're huge gaps, and that's where social status and income start to determine your health. So think about a low-income new mother. She's discharged early, she needs expensive take-home medications, or maybe intensive home-based monitoring. Those costs often fall completely outside that universality promise. And that forces families to choose between necessary follow-up care and, their financial stability.
It's interesting to look at Canada's role internationally, though. Starting way back with the 1974 Lalonde Report and then the 1986 Ottawa Charter for Health Promotion. These documents basically told the world that health isn't just a hospital problem.
Exactly. They really established Canada as a global leader by defining health not just as, the absence of illness, but as a resource for daily life. The Ottawa Charter laid out these 3 major challenges.
Which were?
Reducing the profound health inequities between social groups, boosting disease prevention, and improving people's ability to manage their own chronic diseases. And that led to this fundamental shift toward what we call intersectoral collaboration.
Meaning healthcare has to work with other sectors.
Yes. It means healthcare needs to work with housing, with income security, with education, if we're ever going to truly improve wellness for everybody.
And the government body that handles this, the Public Health Agency of Canada, or PHAC, has had to evolve really quickly.
That's been the reality since it was formed in 2004. I mean, its founding mandate was all about health promotion and population surveillance, but its resources have had to shift and shift significantly toward emergency preparedness and pandemic planning.
SARS, Ebola, COVID-19.
All of them. So this duality, balancing long-term health promotion with that immediate crisis response, It's just a constant tension in public health funding.
Okay, let's unpack this. This shift from just treating sickness
Yeah.
to actually promoting health. It means every nurse has to operate with an equity lens, which means you have to deeply understand the social determinants of health,
Yeah.
the SDOH.
The SDOH are, well, they're all the non-medical factors that fundamentally influence whether a person, a family, or a whole population is healthy. These things like income and social status, employment, education, your physical environment, your access to services, and systemic factors like race and racism, they determine your place in society and your access to resources.
They're the upstream drivers.
Yeah, the upstream drivers of health and illness.
Exactly. That list is huge.
Yeah.
But if we had to pick the single most impactful factor, especially in the maternal child world, where does the evidence point?
Overwhelmingly, it turns to poverty. Income and social status have the most significant influence on compromised maternal and child health outcomes. Full stop.
Right.
And when we talk about poverty in Canada, we use these official measures, right? Like the low-income cutoffs, LACO, or low-income measures LIM. But those definitions don't really capture the challenge for you as a nurse.
You're talking about the difference between visible and invisible poverty. That's a really powerful distinction.
It is because as a new nurse, you'll often recognize visible poverty.
Mhm.
You know, a lack of material resources like poor housing or inadequate clothing. But invisible poverty is harder to see, and it's often more insidious.
What do you mean by that?
It's the social and cultural deprivation. It's the limited educational opportunities, the lack of reliable transportation to get to a specialty appointment, the inferior social and medical services. It's that pervasive sense of just having limited options. Invisible poverty is what trips up our care plans.
So a patient might not have gas money to get to their weekly fetal monitoring.
Exactly. Or they might lack the social literacy to confidently navigate a really complex hospital system. And that results in poor outcomes, no matter how good the advice was that you gave them.
When you look at Canada's global health rankings, we have these really high survival rates, but that overall success, it just tragically masks these profound systemic health inequities among specific vulnerable populations right here.
We see this disparity most acutely in the health of Indigenous peoples, First Nations, Métis, and Inuit. And understanding this isn't optional. It's an ethical and professional mandate for every Canadian nurse. The poor health outcomes that this population experiences, they're not random. They are a direct and ongoing negative consequence of colonization.
And the source material points to specific social determinants that are unique to that legacy.
Yes, the unique factors include the devastating impact of the residential school system, systemic racism, profound social exclusion, deep poverty, and dislocation from traditional lands, languages, and resources. I mean, just consider the sheer weight of the statistics. In 2019, nearly half, 47% of all First Nations children lived in poverty.
47%.
That structural failure translates directly into active barriers to basic health needs like clean drinking water, adequate housing, and access to nutritious food. And all of that just compounds MCH risks exponentially.
The residential school system also created this critical long-term health crisis we now call intergenerational trauma. How do MCH nurses need to approach that in their practice?
Intergenerational trauma means that the severe, untreated trauma experienced by survivors of the abuse and assimilation efforts in those schools, the mental, spiritual, physical, sexual abuse, is carried forward. It affects subsequent generations.
So when those survivors became parents,
They often lacked positive models for nurturing and bonding, or they coped with their own post-traumatic stress through substance use, which just perpetuates a really difficult cycle. So for you as the MCH nurse, this means recognizing that trust might be incredibly difficult to build. A family's reluctance to engage with health authorities could be a very normal protective response rooted in historical government violence. It's not a personal deficit.
and that's where the Truth and Reconciliation Commission comes in.
It calls for all of us, all healthcare providers, to acknowledge this history and to actively support Indigenous-led healing as part of the path toward culturally safe care.
Okay, let's move to another highly vulnerable group, immigrants and refugees. We often hear about this initial healthy immigrant effect. Why does that effect just seem to disappear over time?
Well, the healthy immigrant effect is temporary because, yes, they are often medically screened to be healthier when they arrive than the Canadian-born population. But that health advantage erodes, and it erodes rapidly.
Why?
They encounter intense stress, Stress from unemployment, from discrimination, the difficulties getting their foreign credentials recognized, and significant language barriers when they're just trying to navigate our complex health system.
Right.
They face lower incomes, social isolation, and all that stress begins to manifest as chronic illness.
And I imagine refugee status brings a whole other level of vulnerability.
It compounds the risk significantly. I mean, refugees often arrive in Canada after fleeing persecution or war. That means they are extremely impoverished and have endured immense physical and emotional trauma, often complex PTSD. So in MCH care, this history of trauma means you have to have a meticulous, sensitive approach. You have to recognize that a standard clinical interaction, like a routine physical exam or even just hearing loud noises in the clinic, might trigger past traumatic memories.
Let's talk about age-specific vulnerabilities, starting with adolescents. They're always a primary focus for community health promotion.
They are. They're perpetually at risk because of high-risk behaviors, and this risk is magnified for youth from low-income or disorganized family backgrounds. Now, we have seen a positive trend. Teen pregnancy rates are declining, and that's due to better use of reliable contraception.
But there's another concern.
Yes, a major concern is the rising rates of sexually transmitted infections, or STIs. We're seeing significant increases in chlamydia, syphilis, and gonorrhea among adolescent and young adult females. And that just necessitates targeted, accessible, and completely non-judgmental community health initiatives focused on safe sex practices and easy access to screening.
And finally, a growing humanitarian and public health crisis. Homelessness.
And poverty is, again, the central cause here. This population has extremely high rates of chronic disease, infectious diseases like TB, and premature mortality. As a nurse, you need to be particularly attuned to the vulnerability of homeless women,
Who often experience what's called hidden homelessness.
That's right. Meaning they are living temporarily in unsafe, overcrowded, or insecure situations, often because of family violence. These women frequently have extremely high rates of mental health issues and substance use disorders, and they face enormous systemic obstacles to accessing vital MCH services, including prenatal care, childhood immunizations, and cancer screening. We as nurses have a huge advocacy role here to create low-barrier, safe access points for this group.
So, given that every nurse is going to interact with people who have experienced immense adversity, this takes us right into the concept of trauma and violence-informed care, or TVIC. This is fundamentally about changing the system, not about fixing the person.
That is the perfect way to frame it. TVIC is a systemic approach. It recognizes that inextricable connection between violence, trauma, and negative health outcomes and behaviors. The primary goal is just to minimize harm and prevent re-traumatization within the healthcare environment itself.
So it's not about digging for trauma histories.
Not at all. It's about making the entire interaction safer and more empowering for the patient.
Okay, so how do we operationalize that? What are the 4 core principles of trauma-informed care that should guide your daily nursing practice?
The first principle is to understand trauma and violence and their impacts. This means adopting a non-judgmental stance, believing patients when they disclose an experience, and recognizing that their current behaviors or health issues might be adaptive responses to past trauma.
Okay, that's number 1.
The second is to create emotionally and physically safe environments. This involves clear, consistent communication, respecting boundaries like asking permission before a physical touch or a procedure, and just ensuring the environment itself is predictable and calm.
So those first 2 really set that relational foundation. What about the next 2? They seem to focus more on agency.
They do. The third is to foster opportunities for choice, collaboration, and connection. Patients have to feel they have choices about their treatment and services, even small ones. Collaboration means actively involving the patient in the care plan, sharing expertise equally, and making sure the patient really understands the instructions.
And the 4th?
And finally, the fourth principle is to provide a strengths-based and capacity-building approach. This means helping patients identify their own inherent resilience and skills. Techniques like motivational interviewing are crucial here. You focus on what the patient can do rather than focusing on deficits, and you help them develop coping skills for recognizing and managing their triggers.
Which leads us to a really important universal practice alert, universal trauma precautions.
Right. If you truly internalize the prevalence of ACEs and violence, the only ethical conclusion you can come to is to assume that all patients have a history of trauma, whether they've disclosed it or not. So, implementing TVIC standards across all your interactions ensures a baseline of respect, safety, and empowerment that reduces the potential for re-traumatization for absolutely everyone accessing the system.
That concept of history brings us to adverse childhood experiences, or ACEs. For an MCH nurse, why is this link between childhood events and adult health so critical?
Well, ACEs are negative, stressful, or traumatizing events that happen before age 18. Things like abuse, neglect, or household dysfunction like parental substance use, mental illness, divorce. The cumulative exposure to multiple ACEs generates what we call toxic stress. It keeps the body's stress response system constantly activated.
And that physiological overload actually changes the body.
It results in structural and functional changes in the developing brain and body, and the resulting outcomes are, well, they're catastrophic and lifelong. The more ACEs a person has, the statistically higher their likelihood of developing lifelong chronic health issues. Heart disease, diabetes, obesity, cancer, substance use disorders.
So the pregnant parent you're caring for might be dealing with a long shadow of their own ACEs.
Exactly. And it can impact their health literacy, their mental well-being, their capacity for bonding. But, and this is so important, the research emphasizes that this is not a predetermined fate. The negative effects of ACEs can be minimized or even prevented by focusing on 3 strategies: reducing stress exposure, building responsive and nurturing relationships, and strengthening the life skills of the child and the family.
Let's switch gears a bit to how technology is simultaneously advancing and complicating MCH care. On one hand, we have these astonishing advancements in high technology care, sophisticated fetal monitoring, incredible survival rates for very low birth weight babies in NICUs.
Right.
But on the other hand, we have to navigate the ethical minefield of social media.
Social media is such a double-edged sword for the nursing profession. It's great for collaboration, for peer connection, for quick resource sharing, but the potential for harm is enormous, primarily through violations of patient privacy, confidentiality breaches, and reputational harm to both the nurse and the institution. You have to understand that posting even anonymized details can lead to disciplinary action.
So to guide this, there's a framework called the 6 Ps for social media use. We need to integrate these professionally.
These guidelines are the professional standard. First, be professional at all times. Second, keep your posts positive. Third, maintain absolute patient-person-free content. That means 0 identifiable information.
That's a huge one.
Huge. Fourth, protect yourself, guard your professionalism. Fifth, prioritize privacy, maintain clear boundaries between your personal and professional life. And maybe the most important one, pause before you post. Think about the long-term implications of everything you share online.
Okay, moving from digital practice to clinical guidance, let's talk about the imperative of evidence-informed practice, or EIP. Why is this so necessary in modern MCH nursing?
EIP is the continuous, systematic process of collecting, interpreting, and integrating the most valid, applicable, and relevant information available to guide your decision-making. It includes formal research, yes, but also patient-reported data and the professional wisdom of experienced nurses. It's necessary because healthcare is increasingly scrutinized based on cost and efficacy. EIP validates nursing's contributions and ensures that our interventions are based on the highest probability of positive outcomes.
I find it really powerful that the definition of evidence itself is evolving beyond just this rigid scientific hierarchy.
It's a progressive and absolutely necessary shift. We're moving away from only looking at quantitative levels of evidence to embracing multiple ways of knowing. This includes acknowledging the value of personal knowledge you gain through extensive clinical experience and, crucially, integrating indigenous ways of knowing.
And seeing the patient as an expert.
Recognizing patients as experts in their own health experience is essential for a complete, holistic picture of the evidence.
Chapter 1 wraps up by looking at the complex ethical issues that technology and societal changes have just multiplied in MCH care.
Yeah, these advancements consistently force nurses into complex moral and ethical dilemmas. For example, how do we allocate scarce resources for expensive reproductive technologies? What's the standard of care for a VLBW newborn who is right on the threshold of viability? What are the implications for informed consent when you're caring for an older adolescent who is refusing life-saving treatment?
You can't navigate those alone.
You can't. You must use the CNA Code of Ethics for registered nurses as your foundational framework for making collaborative, ethical decisions that uphold the core responsibilities of nursing, things like truthfulness and justice.
So before we move to the micro level of the family, let's briefly touch on 2 macro level connections: interprofessional education, IPE, and the Global Sustainable Development Goals, SDGs.
Right. IPE involves faculty and students from different health professions, nursing, medicine, social work, pharmacy learning, to collaborate effectively to foster patient-centered care. The 6 competency domains for IPE, things like communication, role clarification, and conflict resolution, these are non-negotiable skills that ultimately lead to safer patient outcomes, especially for complex MCH issues.
And the SDGs replace the MDGs as the global blueprint for MCH improvement.
They did. The 17 Sustainable Development Goals, adopted in 2015, aim for a sustainable future by 2030. SDG number 3, which is focused on good health and well-being, places a heavy emphasis on maternal and child health indicators, reducing maternal and neonatal mortality and ensuring universal access to sexual and reproductive health care. Canada actively participates in these efforts.
All right, so Chapter 1 showed us the huge systemic forces, poverty, colonization, technology, that impact health. So if the system creates these inequities, how do we, at the bedside, use the family unit to build resilience against them? Now we narrow our focus from that broad national context down to the intimate world of the patient, the family. And what's fascinating here is that the entire foundation of family nursing starts with this revolutionary idea that there is no universal definition of family.
That is the essential starting point for relational practice. I mean, historically, definitions were tied strictly to genetics, legal ties, or cohabitation. Today, the operational definition has to be broad and flexible.
So a family is what the individual says it is.
A family is what the individual considers it to be, defined by enduring emotional commitment, mutual nurturance, and socialization. As a nurse, you have to adopt this perspective, recognizing relationships based on blood, consanguineous, marriage, a final, or just the unit a person was born into, family of origin.
How does this flexible definition play out in the actual family structures we see in Canadian demographics?
Well, the nuclear family, parents and children, is still the most common for children under 15, accounting for over 73% of those homes. But diversity is the key trend. We're seeing a rise in multi-generational or extended families where grandparents or other relatives live in the home.
Which could be a huge resource.
A vital support, yeah. It acts as a crucial health resource, particularly within many Indigenous, immigrant, and other cultural communities.
And what about the structures that might introduce new vulnerabilities?
Lone parent families are a significant concern. They comprise nearly 20% of children under 15. Over 80% are female-headed, and these families are far more likely to be dealing with the stress of low income and poverty, which, as we've already established, is the most powerful determinant of poor child health outcomes.
We also see blended families, same-sex couples.
Right, blending families from remarriage, introducing step-parents and siblings, and the growing visibility of same-sex couples and transgendered couples who are actively parenting. So as the nurse, you have to assess the dynamics of these families, not just the structure.
Regardless of how the family is configured, it's the dynamics, how they interact, that matters most for MCH outcomes.
Absolutely. The family is the primary source of nurturing, socialization, and the development of a child's identity and self-worth. It's also the incubator for problem-solving skills and the transmission of fundamental cultural, religious, and health beliefs. So effective family nursing requires you to identify and actively build upon these inherent family strengths.
This collaboration is what defines family-centered care, or FCC. What are the key principles that anchor FCC and guide our collaboration with the family?
Well, FCC insists that care must be collaborative, safe, skilled, and individualized. The principles demand a holistic approach, so we're considering the mental, spiritual, social, and physical health of the entire unit. Crucially, FCC mandates that care must be culturally appropriate.
And that specifically includes recognizing Indigenous knowledge.
Specifically recognizing the unique knowledge and traditions of Indigenous peoples, minimizing travel distance for care, and ensuring that provider attitudes and language are respectful and non-judgmental. FCC isn't a project, it's a philosophy.
To guide the assessment of these complex dynamics, nurses rely on foundational family theories and models. Why do we need these theories if we're just talking to the family?
The theories provide a systematic lens. They help us organize massive amounts of data and predict where stress is likely to occur, which lets us intervene proactively. For example, family systems theory views the family as an interconnected unit.
The idea of circular causality.
Right, the central idea is circular causality. A change in one part of the system affects all the others. If an adolescent develops type 1 diabetes, that isn't just a clinical problem for the child. It disrupts parental roles, it stresses finances, it changes how siblings interact. You have to assess how the whole unit adjusts to maintain stability.
So the goal is homeostasis. keeping the system in balance.
Precisely. And you can contrast that with the family life cycle theory, which looks at the predictable stages families move through, like the arrival of the first child or the departure of the last. This theory focuses on the developmental stresses that naturally happen during those transitions.
And then there's the family stress theory.
The family stress theory gives us a framework for understanding a family's reaction to a major stressor, like a severe accident or diagnosis. It distinguishes between the internal context, what the family can control, like their coping mechanisms, and the external context, which are societal or economic factors they have no control over, like a recession or systemic racism.
That distinction seems incredibly helpful when a family is struggling with adherence. If they miss an appointment, this theory helps you understand if that was due to internal factors, like disorganization, or external ones, like the bus schedule or losing a job.
It shifts the blame from the patient to the circumstances.
Exactly.
In terms of direct nursing models, the McGill model of nursing is strength-based. It moves away from a deficit model.
Right.
It emphasizes identifying and developing inherent family strength. And this model is highly relevant in MCH because pregnancy and childbirth are considered a teachable moment when families are super motivated to adopt healthy behaviors for their child.
Okay, so putting all this theory into action requires structure. The Calgary Family Assessment Model, or CFAM, is the standard framework. How do you use this model to gather data systematically?
The CFM guides you through three major interconnected categories. The structural assessment looks at the internal components: composition, boundaries, who's included and excluded relationship patterns, and the external context like ethnicity, social class, environment.
So that's the who and where.
Exactly. Then the developmental assessment tracks the family's predictable life stages and their transitional tasks. And finally, the functional assessment evaluates how members behave toward each other. Both instrumental functions, like activities of daily living, and expressive functions, communication, emotional roles, and problem solving. It just ensures the assessment is comprehensive, not just focused on the presenting physical issue.
And beyond the verbal interview, we use visual tools to quickly grasp these complex dynamics. Tell us about the genogram and the ecomap.
The genogram is a graphic representation. It's basically a family tree that documents relationships and health history across at least 3 generations. It uses standardized symbols to depict marital status, conflicts, and health conditions like cancer or substance use. Its power is in providing a quick visual snapshot of intergenerational health risks and family patterns. It's invaluable for counseling and risk assessment.
And the ecomap looks outward.
The ecomap graphically portrays the family's social relationships and support systems. You draw the family circle in the middle and then radiate lines out to external resources, extended family, church groups, work, schools, health clinics. The lines you use indicate the strength or the strain of that connection. The ecomap helps you identify if a family is socially isolated, where their external resources are, and where they might have network gaps that need bridging.
This emphasis on connection brings us to relational inquiry lenses. They force the nurse to go beyond just a checklist.
Relational inquiry demands that you are constantly attuned to the context. The 4 lenses give you different ways to look at a situation. The phenomenological lens explores the family's subjective lived experience. What does this illness actually mean to them?
Okay.
The sociopolitical lens attends to how power, class, race, and systemic biases are shaping the family's opportunities and access. The spiritual lens recognizes the personal and religious meaning they attach to health events. And the socio-ecological perspective views the family within its community environment, recognizing that their choices are supported or constrained by their context.
All of this leads to the most important relational mandate in Canadian nursing: achieving cultural safety and humility. We have to define culture clearly first, though, moving away from old static ideas.
Right. Culture must be viewed as dynamic and complex, a relational process influenced by life experiences, social position, and gender, not just race or ethnicity. And we first have to confront the obstacle, which is ethnocentrism.
Viewing one's own culture as superior.
Yes, which leads directly to stereotyping and ineffective care. And from there, we see this progression in language moving past cultural competence.
Right. Cultural competence was sort of the first step.
It was the starting point, focused on acquiring knowledge about different groups, but it was rightly criticized because it often led to a checklist mentality, fitting people into stereotypical molds rather than acknowledging individual variation. The Indigenous community really championed the shift to 2 superior concepts.
Cultural safety is the outcome and cultural humility of the process.
Precisely. Cultural satiety is the goal and the outcome. It means shifting the power to the patient and allowing them to determine if the care they received felt safe, respectful, and free of discrimination or racism. The onus is on the system, not the patient.
And humility is how you get there.
Cultural humility is the process. It demands that you, the nurse, engage in continuous, honest self-reflection about your own personal and systemic biases, approaching every interaction as a humble learner. A powerful example of this is recognizing that our highly individualistic North American culture often lacks the vital support systems that are common elsewhere, like Doing the Month, where extended family provides complete support for a new mother postpartum. Humility is acknowledging the stress this places on a nuclear family here.
Let's talk about some practical challenges in this diverse context, starting with communication barriers.
When language is a barrier, you have to be precise.
Right.
We must distinguish between an interpreter who facilitates real-time oral communication and a translator who handles written documents.
And when you're working with an interpreter, there are rules.
The protocols have to be rigorous. The single most important rule is that you must never use a child or a family member as a professional interpreter unless it is an absolute crisis. This protects the patient's privacy, and it ensures accurate technical information. You must address the patient directly, maintain eye contact with the patient, and speak slowly in manageable chunks, allowing the interpreter to work effectively.
What about nonverbal communication, like personal space?
Personal space is so culturally defined. In MCH, touch is constant for assessments, procedures, comfort. But touch without permission can be really distressing, especially across cultural boundaries. You must always ask permission before touching a patient. It's not just about respecting their personal space, it's about upholding their fundamental right to autonomy.
And a patient's internal clock, time orientation. How does this subtle factor affect care adherence?
A person's orientation toward time, past, present, or future, is a deep cultural value. Future-oriented cultures easily adhere to strict schedules and long-term goals, like a follow-up appointment 6 weeks away. But families struggling with the day-to-day survival are often present-oriented.
They focus on immediate needs.
Exactly, and this is critical for MCH. A present orientation means they may value immediate needs over a future follow-up appointment for a newborn that seems perfectly healthy today. You can't interpret this as a lack of caring. It's an adaptation to their immediate environment, and you have to plan care accordingly by finding immediate high-value incentives or reminders.
Finally, Chapter 2 emphasizes spirituality as a non-negotiable component of holistic nursing care.
Spirituality is defined by whatever gives a person ultimate meaning and purpose in life. It's distinct from religion, which is the more organized, formal expression of that. It's an ethical responsibility for you as a nurse to be attentive to the spiritual dimension. Health challenges, especially in childbearing or pediatrics, often raise profound spiritual questions about suffering, purpose, and hope. Spiritual care is relational. It means being present, listening, and supporting the family's search for meaning.
This includes recognizing profound moments, even in tragedy.
Yes. The concept of the pause, for instance, which is increasingly used after a patient death, is a spiritual act. It allows the clinical team a brief moment of silence to acknowledge the life that was lost, to achieve some spiritual closure, and to support each other. Spiritual assessment just requires open-ended, non-imposing questions like, who or what provides you with strength and hope during this challenge? Or what does this experience of suffering mean to you? These questions open the door for genuinely holistic care.
So we've built the contextual understanding from Chapter 1 and developed the relational skills in Chapter 2. Now we look at where so much of MCH nursing is migrating into the community. This is driven by rising healthcare costs, shorter hospital stays, and the evidence that health promotion is most effective locally.
This defines the essential role of the community health nurse, or CHN. CHNs have a tremendously broad focus, promoting, protecting, and preserving the health of individuals, families, and entire populations and systems. They operate with a capacity-building and strengths-based approach in settings from schools and homes to public health units.
And that's different from a home healthcare nurse.
Right. Home healthcare nurses are typically providing specific, intermittent clinical care like IV medication or dressing changes in a patient's home.
So the VHN is focused on population health, which brings us right back to the SDO issue we talked about earlier.
Population health is a strategic approach that explicitly considers those economic, social, and physical environmental factors that determine health. The goal is always to reduce health inequalities by using an equity lens. This means understanding that not everyone starts from the same position, and therefore our interventions have to be tailored to ensure everyone has the same opportunity to be healthy.
When public health officials and CHNs make policy decisions, they don't just wait for a definitive research paper. They use a dynamic framework called evidence-informed decision-making.
The EIDM model shows that public health decisions are a careful balancing act of 5 different components. Scientific research evidence is essential, of course, but it has to be weighed against 4 other factors.
Okay, what are they?
There's the public health expertise. That's the local experienced practitioners' input. There's the community and political preferences, the local culture and willingness to accept a program, the available public health resources budget, staff, infrastructure, and finally, the actual community health issues and local context. The precise magnitude and characteristics of the problem in that specific neighborhood. All 5 of those have to align to create successful and sustainable policy.
Let's delve into the scientific tools that make this decision-making process evidence-informed, starting with demography.
Demography is the statistical study of population characteristics, age, gender, race, socioeconomic status. It helps us predict risk. For instance, demographic data tells us that poverty remains a critical risk factor. The 1.2 million Canadian children in low-income households face higher risks for obesity, limited cognitive development, and lifelong chronic illness because poverty actively impedes healthy brain development.
And age is a factor, too.
Age is a risk factor, yeah. Infants have higher mortality from congenital malformations, adolescents from accidents, and middle-aged adults from cancer.
The second core tool is epidemiology, the science used to track the distribution and causes of disease. This requires precise measurement of morbidity rates.
Epidemiology relies on clear metrics, and we have to distinguish between 2 key measures. Incidence measures the occurrence of new events in a population over a specific period, divided by the population at risk.
So for MCH, that could be the number of new cases of gestational diabetes diagnosed this year.
Exactly. Whereas prevalence measures the number of existing events in a population during a period, divided by the population at risk. So that would be the total number of children currently living with asthma in that community. Both are vital for understanding the full burden of illness.
And to understand why a disease is happening, they use the classic framework, the epidemiological triangle.
The triangle highlights the 3 interconnected factors that all have to be present for disease risk to exist. The agent is the cause. It could be a bacteria, a chemical, or a physical stressor. The host is the individual and their intrinsic factors, like genetics, lifestyle, immunity. And the environment is the setting climate, housing quality, neighborhood.
Can we apply that to an MCH problem, like pediatric asthma?
Perfect example. The agent might be mold or dust mites. The host is the child with the genetic predisposition to sensitivity. The environment is damp, poorly ventilated housing. A change in any one of those factors, moving the child, treating the environment, or managing the host's symptoms, can break the cycle of disease.
This structure leads us directly to the action component, the 3 levels of preventive care. Every nurse needs to know these definitions and have relevant MCH examples ready.
Okay. Primary prevention is the most proactive level. It precedes the disease or dysfunction. The goal is to promote health and prevent illness from ever happening in the first place. MCH examples are everywhere. Community immunization programs, universal parenting classes, safety programs promoting car seat and bike helmet use, and healthy sexuality education for teens. It's all about building protective factors.
And secondary prevention is about catching the disease early.
Secondary prevention focuses on early detection and prompt intervention while the patient is still asymptomatic. The most high-impact MCH example is newborn screening tests, which detect metabolic or genetic disorders before irreversible damage occurs, allowing for immediate treatment.
PAP test to developmental screening for toddlers.
All secondary prevention. But the caution here is that screening has to be warranted. The benefits must significantly outweigh the risks and costs, like the inherent risk of miscarriage that comes with an invasive screening procedure like amniocentesis.
And finally, tertiary prevention happens after the illness is already established.
Tertiary prevention aims to prevent deterioration, manage the disease, and restore the individual to their optimal function. Examples include rehabilitation after a stroke or special education programs for children with developmental challenges. A perfect perinatal example is the aggressive management of gestational diabetes. Managing GDM is tertiary prevention because you're aiming to prevent the pregnant person from developing long-term type 2 diabetes later, and at the same time, reducing the child's lifelong risk for obesity and diabetes.
Now let's apply the classic nursing process to the community setting. The focus shifts from the individual to the entire population.
The 4 steps are the same: assessment, diagnosis, planning, intervention, and evaluation. But the scope just broadens dramatically. The assessment phase involves identifying the unique characteristics, assets, and needs of the entire target population. You're looking at the people, the environment, and the healthcare delivery system.
What are some specific data sources a CHN would use that are different from a bedside nurse?
They're looking at population-level data. Key sources include local health departments for raw data births, deaths, morbidity rates. Also, Statistics Canada census data, which can be broken down by specific census tracts to accurately identify vulnerable, high-risk subpopulations. And they also rely heavily on key informants.
Community leaders.
Community leaders, principals, faith leaders, people who provide unique insights into local issues and priorities that statistics alone just can't capture.
Okay, so once all that data is aggregated, how does the CHN move toward a diagnosis and a plan?
The diagnosis involves comparing the community's health status against a standard, either a time comparison like current STI rates versus last year's, or a place comparison like local immunization rates versus the provincial average. A community diagnosis connects the problem to its underlying cause. For example, increased rates of low birth weight related to poor maternal socioeconomic environment and limited access to early prenatal care.
And the planning has to be measurable.
The goals have to be measurable. If the problem is low bike helmet use, the goal has to be something like, within 1 year, 90% of children participating in the bike safety program will report always wearing a helmet.
And when it comes time to evaluate if a community program actually worked, the classic framework is Donabedian's model.
Donabedian's framework assesses the quality of care through 3 dimensions. Structure refers to the attributes of the setting staff qualifications, availability of equipment, the budget. Process assesses whether standardized good practices were followed during the program's implementation, and outcomes measure the ultimate impact on health status. Did the measurable goals, like that 90% helmet usage rate, actually happen?
We have to also address the most personalized form of community nursing, home care nursing. This is that intermittent clinical care driven by short hospital stays and high-tech care like central lines. It requires careful patient selection.
Patient selection is vital. Referrals have to ensure the patient's condition is stable enough for intermittent observation, that the necessary professional services are available in that area, that the family has the psychosocial and economic resources to manage the care, and that the care is cost-effective. The home visit itself has to follow a rigorous protocol.
Walk us through the key phases of that protocol.
It starts with meticulous pre-visit preparation, arranging the appointment, defining the goals, reviewing the patient's data, and planning your route. During the in-home intervention, your first task is relational building trust and establishing rapport. Then, the systematic assessment begins. This has to be extensive, including a physical exam and a deep psychosocial assessment, and critically, an environmental scan for safety hazards, peeling paint, inadequate sanitation, medication storage, and available resources.
And you end the visit by recapping.
You conclude by summarizing the care plan, reinforcing your teaching, and clarifying the follow-up expectations.
The required psychosocial assessment is particularly extensive in the home, isn't it?
It is, because you are right there in the patient's context. You have to assess the primary language, health literacy, the quality of the social support system, who helps with childcare, who helps in a crisis, the primary caregiver's knowledge and skills, and crucially, any signs of caregiver strain. Caregivers of complex MCH patients are highly vulnerable to burnout, and you have to proactively identify those stressors to prevent a breakdown in the system.
The unique challenge of home care, unlike the hospital, is the lack of a controlled environment. And that raises significant concerns about safety and infection control for you as a nurse.
Personal safety is paramount, particularly when you're entering unknown neighborhoods or homes where a history of violence might be present. Strategies include being acutely self-aware, doing an environmental assessment immediately when you arrive, making sure your employer knows your itinerary, and planning how you'll deal with aggressive behavior.
And infection control.
In terms of infection control, even in the home, the fundamental truth remains. Hand hygiene is the single most important infection control procedure. Hands must be washed with soap and water before and after every patient contact. If running water isn't available, alcohol-based hand sanitizer is essential.
Finally, let's wrap up with the role of technology in providing continuous, low-cost MCH support in the community.
Technology really bridges the access gap. Phone and online health support like nurse advice lines and provincial telehealth services provide critical, continuous support. Telephone triage is a vital application of this. Triage nurses use structured guidelines to systematically assess the caller's background, their chief concern, the severity of symptoms, and duration.
Which allows them to give structured advice.
Exactly. It allows them to structure advice ranging from an immediate 9/11 referral to a same-day appointment or just simple home care advice. This empowers parents, ensures appropriate access to care, and significantly reduces unnecessary visits to the emergency department. So if we synthesize these three foundational chapters, the lesson for Canadian MCH nursing students is clear. Effective practice is fundamentally relational and contextual. You are not simply treating a diagnosis. You are partnering with a family that is embedded in a complex social system.
You have to couple your clinical skills with a deep understanding of the environment. That means acknowledging the impact of colonization and poverty through the lens of the social determinants of health. It means operating with universal trauma precautions, recognizing the dynamic definition of the family unit, and embracing cultural safety and humility as continuous processes.
And understanding your role as a community health nurse, applying the three levels of prevention and utilizing population health tools like epidemiology and demography, that is the strategic blueprint for providing equitable and safe care within the Canadian system. Without that context, your technical skills will inevitably fall short.
And that brings us to our final provocative thought for you to consider as you move forward in your studies. The source material is unequivocal that significant gaps in health equity persist for vulnerable populations in Canada, particularly for Indigenous children. So how can nurses, armed with this essential knowledge of trauma-informed care and relational practice, move beyond simply reporting these inequities and documenting them on a chart to becoming truly effective policy advocates and genuine partners in community transformation, challenging the very system that creates the suffering in the first place? That is the real challenge ahead.